So welcome to today's event, Epidemic Illusions on the Coloniality of Global Public Health. I'm Charles Briggs. I'm the co-director of the Berkeley Center for Social Medicine, one of the sponsors of today's event, and I would like to thank the Othering and Belonging Institute and the School of Public Health, both at UC Berkeley, for co-sponsoring the event with us today. I'd also like to thank Deborah Lustig for her skillful organization of the event, and special thanks also go to Professor Denise Hurd of the Berkeley School of Public Health and Center co-director, Professor Seth Holmes. The format for today's event is that first Eugene Richardson will speak about his book for about 30 minutes. Then each of our distinguished respondents, Bonnie Duran and Troy Duster, will talk for about 10 minutes about the book. Then we will have a Q&A. So please, if you have a question, use the Q&A function of the webinar, and then I will read your questions. And now it is my great pleasure to introduce Eugene Richardson. Dr. Richardson is a physician, anthropologist, and an assistant professor of global health and social medicine at the Harvard Medical School. He previously served as the clinical lead for Partners in Health's Ebola response in the Kono district, Sierra Leone, where he continues to conduct research on the social epidemiology of Ebola virus disease and COVID-19. He has also worked as a clinical case management consultant for the World Health Organization's Ebola project in Benin, Democratic Republic of the Congo. Most recently, he was seconded to the Africa CDC to join their COVID-19 response. His overall focus is on biosocial approaches to epidemic disease prevention, containment, and treatment in sub-Saharan Africa. As part of this effort, he is chair of the Lancet Commission on Reparations and Redistributive Justice. Welcome, Eugene Richardson.
Thanks so much. It's a real honor to be here today. And I'm looking forward to, I'm going to get through these slides quick so we can join our distinguished panelists, Prof. Duster and Duran. I'm really looking forward to it. And a special thanks to ISSI and the School of Public Health and the Center for Othering and Belonging, Seth and Denise and Deborah for bringing this all together. All right. So, book is called Epidemic Illusions on the Coloniality of Global Public Health, and here is the Harvard Medical School shield, which essentially sums up the book in a nutshell or in a GIF. Usually, it says Veritas for truth, and I altered it to say Monopolium Veritatis, or monopoly on truth, and the idea is that these centers of knowledge production, can impose ways of seeing the world, impose ways of parsing phenomena, impose ways of interpreting social and health phenomena on people in the global South, such that they achieve a monopoly on truth. And the book is an exploration of how, in particular, epidemiology as the vehicle for global public health science does this imposing. So I have no financial relationships with commercial entities to disclose. Here's a cover of the book, and it's also summed up in this figure here, which is a play on Plato's cave. So in the original Plato's cave, there's a single cave. People are chained to the wall, and all they can see are the shadows from these figures. Here's a coronavirus. And what happens is one of their lot, usually the philosopher or the social scientist, in our case, escapes from the cave, goes into the sun, into the outside world, and comes back and says, oh, you've only been seeing shadows. This is what things really look like. Here is how to interpret these figures you're seeing on the wall. And that's sort of the universal approach, the positivistic approach to knowledge production. Instead, if we thought of the cave allegory as a warren, where there are many different boroughs, many different ways of parsing phenomena that vie for the forefront of our consciousness. And no one has more of a claim on capital T truth than the other. They all essentially are ways of seeing, ways of being that we come to agree upon. And this is what is also known as a pragmatist notion of truth, that truth is what we come to agree upon, hopefully when everybody has, equal say at the table, Habermas's ideal speech situation. But as we know, that's not what happens in the real world. What we have are entities like universities, like schools of public health, like churches that carry with them Western cultural imperialism and end up imposing ways of interpreting phenomena. And these ways usually support elite interests. And so that is part of what the book does too, is, traces how these interpretations, which look like they are just objective public health science, how they actually do ideological work. And it's based on a varieties of global public health experience. So to play on William James and pragmatism, mostly from my work in West Africa on the Ebola outbreak, here in DRC with a different set of personal protective equipment. And then currently, this is what we're wearing in the hospitals for the COVID outbreak. And I'll just take a quick, for some of the students that might be joining us, a quick experience that was, I guess, somewhat formative in 20 years ago, but in eventually developing the book, was when I worked for Doctors Without Borders as the lab supervisor for a field hospital. This is before I went to med school. And here's the lab right here of our thatched roof hospital. Here's the team. Here's where we lived. Here are the wards, nurses, bed nets, charts. This is what got me thinking that humanitarian aid and global public health might not be all it's billed as. So this is a picture of a burnt out village in central Sudan. And what was happening was that the Arab paramilitaries, or mujahideen, were burning villages in central Sudan and sending people south so that the Chinese could do oil exploration kind of uninterrupted. And then the people were being collected in these internally displaced person camps in the south, and NGOs were setting up next to them to take care of them. Mostly we were treating acute malnutrition, visceral leishmaniasis, malaria, and TB. But what we were also doing was paying a nurse $100 a month. And apparently that $100 a month could support up to extended families of up to 40 people. And I was talking to some of the Arab doctors at a military garrison nearby, and they said to me, this MSF mission is all part of Khartoum's plan in the civil war against the South. And this was before it was two countries. That essentially what they were doing is sending people to displaced person camps. We were keeping them there, paying them, taking care of them. And because of that, they weren't really swelling the ranks of the SPLA, the Southern People's Liberation Army, because you really have to hit rock bottom to join that outfit. And so as they build it, we were preventing independence from being won. And so, obviously that wasn't going to change MSF's mission, which was to carve out humanitarian space and save the lives in front of you. But it got me thinking that, okay, so, what sort of uses can humanitarian aid be put to, whether they are, ideological, ethical, all of that. But how do you know? Like, how could you even measure? No one has omniscience to know whether we were actually doing this population a disservice by providing these services. But it just got me thinking about the double-edged sword that is, humanitarian work and aid. And then I started reading, people like Kwame Nkrumah, who, as early as the 1960s, was already saying things like, aid is a revolving door that, a little bit is given with one hand to disguise what's being taken with the other. And so as I read more and as I, worked in more in different places, I started to see this as more evident, but I also started to see how what we call even public health science sort of colludes in this revolving door, how participates in the carousel. So a quick word on my positionality, as the white privileged male at Harvard. My aim is not to represent the suffering or the experience of individuals in the global South. Where I trained at Stanford told me, oh, Gene, you're way too applied. And I said, thank you. And they said, no, that's not a compliment. That means you would not get a job here. My goal is really to speak about or report on how the harmers do their harm. Since I roll in these kind of halls of power from Harvard to NGOs to the World Bank to the CDC to the WHO, it's more about seeing how people in the circles that I join commit hermeneutic injustice or epistemic violence. And one thing that I think is important for the public health people is that these moral debates that go on about global North obligations to the destitute sick, and they're often phrased in this as in the way in terms of us being related to them as potential saviors. The global North has developed faster, or we had because of guns, germs, and steels, we just had a random chance of having more resources, and now it's our job to share these resources through the USAID and things like that. But if you really look at it differently, that we are morally related to people in the global South as beneficiaries from a global institutional order that systematizes their oppression, then things look very different. Then interventions turn from aid to actual reparations and reparative justice. And I'll get to some examples of that in a little bit. But the book uses as its framework coloniality, which it was developed by at first by Aníbal Quijano in Peru, but it's not too much different than what Kwame Nkrumah was talking about even decades before. And you can see a little bit of gentrifying. Actually, Kwame Nkrumah is not cited by these South American scholars, even though they're doing similar theoretical work. But that's just a further example of the chains of coloniality. Anyway, it can be described as the matrix of power relations that persistently manifest despite a former colony's achievement of nationhood. It attempts to capture the racial, political, economic, social, epistemological, linguistic, and gendered hierarchical orders imposed by European colonialism that transcended independence and continue to oppress in accordance with the needs of capital accumulation. Ramon Grossvogel at Berkeley has said that the heterogeneous and multiple global structures put in place over a period of 450 years did not evaporate with independence. We continue to live under this same colonial power matrix. We've just moved from a period of global colonialism to global coloniality. And then Sabelo and Ndlovu from South Africa had to say, despite the celebration of decolonization as a milestone in African history, Africa has not managed to free itself from epistemological colonization. And that's essentially what the book is about. I'm trying to report on epistemological colonization, how people's perceptions, how they perceive the world is colonized. And this has been inscribed on the continent and people by mission and secular schools, schools of medicine, schools of public health, religious denominations, and other institutions that carry Western cultural imperialism. And what I tried to do is, like Said did in Orientalism, looking at what was considered great examples of literature and showing how they carry Western cultural imperialism. I was actually looking at epidemiological articles and showing how they carry it. And there's a few examples in the book. So essentially, what epistemological colonization is really about colonizing people's perceptions. Colonialism imposed its control of the social production of wealth through military conquest and subsequent political dictatorship. Its most important area of domination was the mental universe of the colonized, the control through culture of how people perceive themselves and their relationships to the world. One of the examples I use is a Harvard School of Public Health study that went on while I was in DRC. They essentially interviewed a bunch of people trying to find out why the outbreak was so big this time around. And what they found was that people had essentially their ignorance, their belief in misinformation, their belief that Ebola was a bioweapon, their mistrust of vaccines to blame for the outbreak. And that is a way of gathering facts, because people did say that. But if you follow that through, it does support a neoliberal model, where then the correct intervention is, send the field hospitals, send people to help with knowledge, attitude, and practices, create WhatsApp groups to convince people that the vaccine is in their best interest. And when you really sit down and talk to people, and you hear them, you find out that it's not lost on them that their ancestors had their hands cut off by King Leopold for not gathering enough rubber, that the Belgian colonial extraction was even more deadly, that the US and Belgium colluded in assassinating their first elected prime minister in Patrice Lumumba, that the US then installed a Cold War puppet dictator in Mobutu, who took a little bit of money to be able to reign from Kinshasa, while allowing our corporations to ransack the East. And DRC is one of the richest countries in the world, but you would never know it if you went there, because but just using the example of a modern gold mine company, Anglo Gold Ashanti, 93% of the wealth comes out of the ground and goes to global North firms. And so this is not lost on them. And as you explore it further, you find that these are actually sophisticated critiques of legacies of colonialism. And so if you see these ideas more as a historical consciousness, as a structured disposition towards eluding further depredation, then again, you're led towards reparative justice as an intervention, more so than just more aid or behavior campaigns. And so, as chair of this Lancet Commission on reparations, redistributive justice, we do have a section on Congo, and all the different sections in this commission are run by people that would benefit from the reparations being paid. And their findings are going to be something like on the order of trillions of dollars owed by the U.S. and Belgium and other previous colonizers. So cultural hegemony. So if exploitative socioeconomic relations are indeed foundational to the social order, as they are in our relations with Congo, and as they are intra US, and this is likely to have a fundamental shaping effect on social ideation. And again, that's what the book tries to do, to show how our exploitative social order finds its way into the way we interpret phenomena, to the way we parse, to the way we take bits out and put them together and categorize them. I've called it a form of bourgeois empiricism, and it builds on Levin's and Lewontin. So models of disease causation that obscure socio-historical forces. So you have your ignorance to blame, not socio-historical forces. They are themselves political acts, which give support to social structures that hide behind scientific objectivity to perpetuate dependency, exploitation, racism, elitism, and colonialism. Another way of describing this imposition of or colonizing of perception is committing symbolic violence or hermeneutic injustice. This can be thought of as the capacity to impose the means for comprehending and adapting to the social world by representing the economic and political world in disguise, taking for granted forms. Here's an article on Ebola survivors in Sierra Leone that we wrote. The book also, it's pretty experimental. It basically starts from the premise that you can't critique modernity using its terms of reference. And so it uses a variety of experimental formats, from flash fiction to reverse ethnography to counter-hegemonic modeling to détournement. Here's one of the détournements, just taking the Ebola poster that you see when you land in Sierra Leone that says, if you get sick, then go to this health center. And, to me, looking at this picture, it kind of reifies that you are suffering because of Ebola, right? Ebola is causing this, and this is where you need to go. When really, if you see Ebola just as a marker is just as like a very downstream marker for all of these forces, from epistemic violence to structural adjustment, Holocaust of slavery, barbaric colonialism, purposeful underdevelopment, and illicit financial flows. Then you see why we have underdeveloped health centers, purposefully underdeveloped health centers in the first place. And this is, to me, a very powerful image. This comes from a 2017 Jubilee publication, where it essentially counted up that $162 billion came into the continent of Africa in the form of aid, loan, and remittances. And $200 billion came out just in illicit financial flows. So illegal theft, trade misinvoicing, tax evasion, resource theft. So the whole idea of aid is a farce. It's a complete farce. We have our U.S. Agency for International Development, but if the continent is a net creditor of $40 billion to the global north, then this really turns the idea of aid on its head and pretty much demonstrates what Nkrumah was saying in 1960s, that it's a revolving door for the illicit financial flows. And again, the book is more about how what we call public health science colludes in these illicit financial flows. And so I'd ask that, epidemiologists and public health practitioners start to see themselves not so much as trying to discover objective truth in the health phenomena they're studying, but rather to struggle against the forms of power, which they are both objects and instruments. I talk about mathematical models of infectious disease transmission and see them merely as fables, really, ways of projecting a future that engages our social imaginary. But for the most part, they engage our social imaginary in very narrow, limited ways that end up supporting neoliberal philosophies, ways that set epistemic confines, the other understanding of why some groups live sicker lives than others. This is symbolic violence. Confines that sustain predatory accumulation rather than challenge it. So here's an example. Here's some modeling done by people at Princeton and MSF. They talk about spatial and temporal dynamics of super spreading events in the 2014-15 West Ebola epidemic. Even though they talk about super spreading events in the title, the paper itself uses the word super spreader 38 times. And the news media and the interviews with these authors afterwards led to these headlines. Super spreaders drove Ebola epidemic, study finds. This guy drove the epidemic. This guy is responsible for onward transmission because he was one of the 20% that infected 80% of people using Pareto's law. So, and they even say in the paper, if we could only figure out who these super spreaders are going to be, then we can target them and maybe transmission wouldn't be so much. But again, if we interrogate the categories of how we parse phenomena, instead of using this neoliberal, individualistic, or methodologically individualistic approach, and we looked at a more methodologically relational approach, then maybe we'd see him not as a super spreader or maybe as an Ebola patient, but as a personal protective equipment bereft care nexus. To me, that's a completely valid category of describing this person, yet it does very different ideological work. If this is the case, then we're looking at why doesn't he have PPE? Why are there underdeveloped health systems? Why isn't the mining company that's just down the road that's extracted billions of dollars in diamonds and hardly paid any taxes on it not called a super spreader? And me and Rafi and some colleagues he might be on right now put out a paper where we essentially, posited that, taxes from the thefted resources alone would have put a health infrastructure in place that could have stopped the outbreak. So why is that mining company not called a super spreader? It's not called one because it's too neo-Marxist. And that doesn't make its way into, what currently has cultural hegemony as far as epidemiologic methods. So I look at epidemiology as a dispositif, and I like Agamben's extension of Foucault's original defining of apparatuses. I shall call an apparatus literally anything that has in some way the capacity to capture, orient, determine, intercept, model, control, or secure the gestures, behaviors, opinions, or discourses of living beings. And so there's critiques of causal inference and influenced heavily by this article by Sharon Swartz and colleagues, and I recommend it. Also have a critique of big data, and I'll talk a little bit now about regression models and epidemic modeling, how they capture our, they capture our attention. They model futures. They secure gestures into those futures, and in doing so, they end up doing racist work, as I will show. So let's pick on IHME, the Institute for Health Metrics and Evaluation, whose the director I just saw yesterday makes over $600,000 as a public university professor. So our Bill Gates billions distorting public health data, they've given over $600 million to this epidemiological unit alone. And I will argue that, yes, they very much distort public health data. So for example, their COVID forecast from last year, the true number of next day deaths fell outside of their predictions 70% of the time, fell outside of their 95% confidence intervals. So they were completely wrong. Their plunging projections were also used to endorse Trump's work as competent and effective. So they easily served ideological purposes. And we'll talk about that. But I would say that, at least according to Ibram Kendi's definition of a racist policy or a racist analysis, which is one that either contributes to inequality or sustains it. That these forecasts do racist work because they sustain inequalities. They endorse a future. So, right, their job is to forecast something. And so they're recruiting our social imaginary. And all they really say to do is wear masks and social distance. And by recommending those things, we still have a future where the COVID disparities continue to exist, even though the total number of infections might be down. Institutionalized racism is rampant, hyper-incarceration is ongoing, and universal health coverage is denied. In short, they actively delimit, through their exaggerated precision and acceptance of government interventions as status quo, the public's ability to imagine social alternatives. So we tried to imagine some social alternatives, and this is why we formed the Lancet Commission on Reparations and Redistributive Justice. And as far as anti-racist modeling is concerned, we put out this paper last month, Reparations for American Descendants of Persons Enslaved in the US and Their Potential Impact on SARS-CoV-2 Transmission. And I won't go through all of it. Essentially, we did some kind of fancy math that showed that if reparations had been paid, say 10 years ago, that COVID transmission across races, not just in the high risk group of Black individuals, could have been reduced 30 to 60%. It was picked up in the news and by CNN, and we received loads of hate mail, which we're still receiving to this day. That's just an aside. So another output from the IHME, they do meta-regression, and I think it's very easy to show how regressions do political work because you're selecting variables, and your choice of variables, the outcome of the study can be shown to be very different depending on your inputs. And I give an example in the book of where one study shows that USAID is like floating all boats, and all you have to do is add the variable illicit financial flows, and you can show that all that good is offset by the money that's being extracted. Here, IHME is becoming known for their global burden of disease studies, where they really just look at downstream determinants of mortality. And so, say Ami Bola, who is the chief editor-in-chief of BMJ Global Health, has openly asked, is it ethical to publish estimates of global burden of disease study when they command so much attention, when they really reify our view of global health suffering as being determined by hypertension, excess salt, tobacco, road crashes, that kind of stuff. And my response to that would be, well, let's think of it in another way. If their goal is to improve the health of the world's populations by providing the best information on population health, this might somewhat be like saying they could have improved the health of people enslaved in the US in the 17th and 19th centuries by going to all the plantations, counting how many people died from strokes, heart attacks, and malnutrition, publishing that. Hey, run with it, you guys. There's the best information on why people are dying. We're improving public health. No analysis of power, and therefore they collude, they promote status quo relations of inequality. So in sum, the book is essentially about how we can trace human rights failings to the impoverished discursive infrastructure of objectivist epidemiology, or any social science for that matter. and we can transform global health by transforming its representations. So thank you so much. Looking forward to the discussion. And if there's any questions afterwards, please feel free to email me.
So, Dr. Richardson, thank you so much. It's a wonderful, brief presentation of a very complex and fascinating book. Now I'd like to introduce Bonnie Duran. She is professor in the Schools of Social Work and Public Health at the University of Washington in Seattle. And she is on the leadership team at the Indigenous Wellness Research Institute. She received her Doctor of Public Health from the UC Berkeley School of Public Health in 1997. Her work has included partnering with the Navajo Nation, Indian Health Service, the National Congress of American Indians Policy Research Center, and other tribes and indigenous community-based organizations on projects aimed at health equity, improving health services, and developing culture-centered health promotion. Welcome, Bonnie Duran.
Thank you. I'm really delighted to be here. And before I get started, I actually went to UC Berkeley, and I'm a first-gen college student. And because of the wonderful faculty at the School of Public Health, I'm thinking of specifically Mary Minkler, who was an incredible mentor to me, and Denise Hurd, who was also an incredible mentor to me. I just want to reach out and thank them for having high ethical values and how they run the program, because ethics, it's all about ethics. Ethics determine our level of happiness or not. So I have a few slides I'd like to share. Would that be okay? Up here, let me go here and go to start. So, as Eugene was talking about, Western science, or I want to make a distinction. It's not Western science, it's Western scientists have a particular framework. And it's something like this. What do we want? Evidence-based change. When do we want it? After peer review. And that's not what the people marching in the streets are saying. So what are the assumptions of the Western episteme? And Eugene talked about how it had an impact globally. Hey, guess what? It had an absolute impact as a huge support of settler colonialism in the United States. It subjected African descent people to less than human, and indigenous people as invisible and dying out, and also less than human. What are some of the assumptions of that? That Western values and culture are universal and the pinnacle of social evolution. Everyone should actually look like middle class or higher class Western people, and I think, as Eugene alluded to, that means that there's more space for the markets of the West, right? That science is neutral, subjectivity is universal and transparent. If you resist that approach, you're just ignorant, and that learning is unilinear. Those are some of the, inherent unconscious assumptions of science, of Western science, that indigenous and other historically marginalized communities are fighting against. I mean, we can trace federal Indian power to exactly what Eugene was talking about global health. That happened here as well. Annihilation of native languages, kids getting kidnapped to go to boarding schools where they were forbidden to speak their language and taught to be as European American as possible. In fact, those are still the standards of healthiness. If you look at them, there's a huge cultural component to those things. Traditional medicine was outlawed. This is what people were doing. They were doing cultural genocide in the United States. This is the kind of, we need to acknowledge that we are the legacy of this, and make sure that we're really investigating, how neutral our science really is. I could go on in days. And what are the alternatives to this? I think that Eugene talked a bit about knowledge democracy. The foundational principles of that is that understanding of the world is much broader than a Western understanding, and that there will be no global social justice without cognitive justice, and that in order for us to be liberated, collective liberation, it's probably not going to be on a Western viewpoint. Here's an indigenous episteme that is huge, Sumac Cauce or Bien Venir. It is the acknowledgement that humans are part of nature too. And we know that Bolivia and Ecuador have changed their constitutions to give equal rights to nature that humans have. And actually some of the tribes in the United States have done the same thing. They've changed their constitutions in order, along the Sumac Cauce way. And, you like all the same references I like, Eugene. Epistemic injustice. I love Miranda Fricker's work that I particularly like hermeneutical injustice. For any historically marginalized group to even know what's happening, they need space to do their own meaning making. That happened in Indian country in the late 70s, early 80s, and early 90s. And what did we come up with? We came up with a theory of historical trauma. And that was a theory of ideology rather than being primitive and uncivilized and having a culture that was no good. We came up with the theory of ideology that said, hey man, it's our colonial history that determines or that is, responsible for our health inequity. It's not us, it's you. And that's a huge theory right now in indigenous communities. I think it might have started in the Jewish community. African-American communities are out also, I think it's post-slave syndrome or something like that. And it's true, we invented this in the 1980s and everybody said, oh, that's native folktales. But then epigenetics came out and proved that it was actually true. So here's the questions that we need to ask ourselves as we go forward, taking into consideration exactly what Eugene was talking about. How do we decolonize, deracialize, demasculinize, and degender our inherited intellectual spaces? How do we contribute to the building of new academic cultures that respect epistemologies of the global South? And how do we become part of, just collective liberation? So I totally agree with everything that he said. Was that 10 minutes?
You were certainly fine in terms of time. All right, so are you, well, thank you so much, Bonnie. I really appreciate that, Dr. Bonnie Duran.
I do have one question for Eugene. Can I ask it later, huh? Yeah, so I also have, I'm a first-gen college student, and I got through UC Berkeley doctoral programs because of my Buddhist spiritual community and, just the benefits of epistemologies of the global South for healing. So I'd like, do you want to say just briefly how that informed the work that you're doing?
Sure, thanks. I didn't mention it alongside the Sudan experience, but right next to that Sudan experience, I had done a master's in essentially Eastern philosophy, Buddhist studies, Asian studies. And so I draw on my kind of thesis at that time was on the Huayan Chinese Buddhist tradition, which eventually became Chan and then Zen, where I think I really picked up on what a relational approach might be, or in social science, we would call a methodologically relational approach. And that really, filters out through the book, trying to see people not as these bounded liberal agents with all sorts of power and perfect knowledge, but as nodes in a network where what is done over here has ramifications for over here. So yeah, it's been very helpful for me just seeing the interconnectedness of phenomena.
Thanks again, Dr. Duran. So I'm now pleased to introduce Dr. Troy Duster. He is the Chancellor's Professor Emeritus at the University of California, Berkeley. He's the past president of the American Sociological Association and he served as chair of the board of directors of the American Association of Colleges and Universities. Among other publications, he is the author of Legislation of Morality, Law, Drugs, and Moral Judgment, and Backdoor to Eugenics. In the late 1990s, he chaired the Human Genome Project's National Advisory Committee on Ethical, Legal, and Social Issues. He's the founding director of the Institute for the Study of Societal Issues, which is the parent institution of the Berkeley Center for Social Medicine. And I'm very pleased to say that he is also an affiliate of the Berkeley Center for Social Medicine. So please welcome back to your own institution, Dr. Duster.
Thank you very much, Charles. I want to begin with a quote from Paul Farmer, who says appropriately, Eugene Richardson is not only one who talks the talk, he walks the walk. That is, he not only writes about the under-theorized collusion between epidemiology and colonialism, he gives us tools to think about it because he's been in the scene, in the search himself. Now, one of the central elements of this collusion is what Gene calls the emerging hegemony of big data as the go-to explanation for health outcomes in formerly colonized countries. Another key element is Gene's contribution to the idea of the importance of the language we use. I love the framing he did around the super spreader, because when you get to the actual analytics of what goes on with epidemiology, the health sciences, there's a tendency, overwhelming tendency, to locate the problem inside the individual and talk about how the individual's problem can be solved by addressing the individual's circumstance, the super spreader. And in Gene's example, he says, well, what about the corporations that pollute the environment? If you call them super spreaders, you're being called political. If you look only at the individual and his or her condition, you're doing science. So let me take a couple of examples from my own interest here and show you how this works in terms of the American scene. My favorite example is the Pima Indians, who are the poster child of diabetes. It is the group with the largest proportion of its population who are afflicted with diabetes in the known world. So, for example, women over 50 among the Pima have over 55% incidence of diabetes. Now, because of that, scientists fly in from all over the country to get blood samples, and especially in the last period of big data, looking for genetic markers. And if they find them, they'll publish articles which show that they've concluded that this particular configuration of genetic markers, SNP patterns, help explain the high incidence of diabetes among the Pima. And that's called science. That's high science. But it turns out that at the turn of the 19th century, early 20th century, we also have data on the Pima. They had absolutely no diabetes. Let me repeat that. 120 years ago, we had data on the Pima. They had no diabetes. So why are we looking at the genetics of diabetes in 2010, 2015? It's because that is the imprimatur of science. On the other hand, as I'm sure Gene will agree, if you take a look at the forces at play between 1905 and 1940, you would see that the Pima Indians were robbed of their livelihoods by the way in which the waterways were diverted to help whites. And so the diet of the Pima Indians dramatically transformed in that period. No reason to go into great detail here, just to tell you that by the 1950s, the diabetes rates began to soar because of the ways in which certain kinds of flour and sugar were poured into the Pima population. Now, If in Washington, I come to a table and I talk about this issue, they will call me political because they'll say, that's a policy issue. That's not a science issue. And here's where Gene's insight about the linguistic turn is so important. I would go so far as to say that anything that is inside the body, blood, DNA patterns, you can go down the line. You publish an article on that topic, and that's called science. If, on the other hand, you come outside the body and talk about policies which explain why the Pima Indians' diabetes rates have been transformed over a full century, that's called political. And I speak here from direct knowledge. I sat on boards at the NIH for many years, and I watched this phenomena where the people who were the biochemists on the panel sneered effectively at those who didn't have this kind of science inside the body. I have time. I'd like to show a couple of slides which deal with the back framework in which I think this whole setting occurs. At the end of the, let's see here. Share screen. There we go. Here we are. At the last half of the 19th century, there were three or four books that were written which were transformative. First two you'll know right away, Charles Darwin, all about evolutionary theory, Karl Marx. But one of the books that even outsold those two was by Herbert Spencer. Spencer sold 4 million copies of this book, and it was all about the hierarchy of cultures. At the bottom, Aborigines, capable, he said, of only seasonal thought. Next in the line were the Hottentots. They were capable of annual thought. They were still, however, savages, primitives. Then came the nomadic peoples, Lapps, nomads. If you didn't have a stable, sedentary life, you couldn't really carry culture very far. That's the nomadic peoples. Then the sedentaries, hunters, gatherers, fishers, but important, accumulative agriculture was the next level up. Now I go through this because at the very top were, of course, the great civilizations that Toynbee and Spencer wrote about. And at the very top of them all was Oxbridge, Heidelberg, and the Sorbonne. Now this ideation, the notion that there is a hierarchy of cultures, is so deeply embedded in current intellectual life that we cannot shake it off. What I want to do now is to just give you a couple of indications of how deeply this was mired into our view. Cornelius Rhodes, Rockefeller Institute, engaged in experimental work in Puerto Rico, in which he infected human subjects with cancer knowingly. Now I bring this up because I want to tell you what happened, not just with those subjects, but with Cornelius Rhodes. His attitude toward his subjects was chronicled in a letter which later served as the basis for an investigation with regard to what he did. He was exonerated, but here's what Rhodes himself said. What the island needs is not public health, but a tidal wave of something to totally exterminate the population. What happened with Rhodes? Well, as I said, there was an investigation, but he was exonerated, calling Rhodes simply a man of few scruples, but he was doing high science. Now, here's the point. He went on to direct the establishment of the U.S. Army Chemical Warfare Laboratories in Maryland, Utah, and the Panama Canal Zone. And now here's the kicker. Rhodes, this man of few scruples, was awarded the Legion of Merit and was appointed to the U.S. Atomic Energy Commission, the AEC, which later became, it changed its name to the Department of Energy. And of course, that's because of the atomic bombs, which went off. Do I have a few more minutes? If I do, I'll just quickly tell you what I think about these experiments. Okay, this will go quickly, and then I'll turn it back to you, Charles. What few Americans realize is that only about 70 years ago, Puerto Rican women were the subjects of this tiny tablet, an experiment for keeping them from getting pregnant. They were told this medicine would keep them from having children that they couldn't support. And so they were quite happy with this. Half century goes by, it became the longest running experiment of its kind, nearly a decade of veiled research that helped pave the way for a magic pill. What unfolded was, in this period, a remote farming town in the foothills of near Puerto Rico's east coast, hundreds of women were unwitting pioneers of modern sexual revolution. They were not informed, they were experimental subjects to test the world's first birth control pills. And now, a quick change of reflection to what the relevance is to our discussion today. Other test groups in the mainland were actually being given the pill. White women in Boston. But because of the side effects, they were ended in the US. They continued in Puerto Rico. It was here that doctors found their best control groups. The doctors provided hundreds of these women, again, with refined versions of the pill. Until 64, the tests were safe to offer to people at the very apex of Herbert Spencer's hierarchy of cultures. Language, the language of science, is deeply embedded in this collusion. And with that, I'll turn it back to you, Charles.
Thank you so much, Troy. That was fascinating and provocative as always. Now, I'm very pleased to, first of all, we might give a final word of thanks to our three speakers, to Eugene Richardson, to Bonnie Duran, and also to Troy Duster for their exciting presentations. And now we get to have dialogue. I'm sorry I have to sort of moderate that a bit and read your questions, but please forgive me for that. So we have one, I think initially that's going to be, that they're all quite interesting. And frankly, they're probably just the sort of questions that you might like, which are edgy and provocative. So the first one is, I think here directed towards you, Eugene. Might you discuss how you were able to reconcile staying within an academic department of global health, given what you say here?
Yeah, it's hard. I either have to, I'm either deluding myself, thinking that there are ways of keeping a foot in both worlds and trying to change from within, or I'm being co-opted, by the carrot that's being hung out at the end of a tenure track. I mean, I've personally found that I feel like I can go in between the worlds, and what I'm able to weaponize in either one has been helpful. And I'm actually quite proud of this reparations paper we just put out. I think it's a culmination of a goal I've had to actually, use the tools of academia to actually, but still to subvert methods, to still make statements that make it into CNN and get an altmetric of 500 and all that. But you're right, I do think about it all the time, whether how easy it is to be co-opted in this path, and so I'm always conscious of it, and I will hope, and I tell my students all the time too, please call me out when you see the co-optation taking place.
Thank you. The first one was from an anonymous participant. Now we have one from Robert Otto Valdez. First, there was a comment that one might not necessarily want to sort of take temporal priority between different continents, Africa and Latin America, as to who had an idea first, if the practice is decolonial. But he also asks a question. So the Ebola posters are instructive about the situation, but the structural and institutional causes do not heal or prevent the epidemic. So how do we change the institutional and structural causes that influence the health of communities and individuals? Identifying and describing are fine, but we need solutions to these power differentials. And I hope you'll bring in potentially, speaking here as another reader of your book, some of the techniques that you use in the book to be able to try to address that particular question. I think you need to unmute yourself, Eugene.
Sorry about that. Yeah, I mean, I'd love to hear from Bonnie and Troy on this, unless you want to hear me respond again. Do either of you have? Oh, you're on mute too. Troy, are you?
There we go.
Go ahead.
Okay. Yeah. I mean, this is a huge question, the structural forces that play across the globe. You know, one of the issues around global health is who's making the contributions. And Bill Gates is one of these people. It was a wonderful paper written a few years ago about the ways in which billionaires are able to send money around the world in ways that, if they were distributed rather by public health officials, it might be more transformative if it were sent to people with positions of power in those societies. So I don't have a quick or good answer, but I'm happy to at least open up this discussion with this notion, the way in which the tax structure permits billionaires to evade taxes by contributing their money to the alteration of the way healthcare is given around the world, educational programs are developed, and so forth. That's an interesting issue.
Yeah, I mean, I think that leads directly to some of the stuff I comment on the book, which is, every solution for me seems to be moving more and more into the reparative justice area. And I'd even go into WHO meetings in the DRC, and they would say things like, oh, only 10% of the people in this village took the vaccine. How can we get people to take the vaccine? And I'd say something like, how about we get $100 million, pay people to take the vaccine, and that $100 million is committed as the first installment of Belgium's $5 trillion reparations payment, which will go to everything else that's been looted from the place. And really, that's going to mean these countries are going to have to do some form of huge tax on the wealthy, which would easily pay for it, and then go to the redistributive justice part to pay for reparative damages. I mean, think of the example of India. Utsa Patnaik, an economist in India, calculated that the UK stole $45 trillion during colonial times. I mean, these are huge transformative historical thefts that need to be repaired. So I think, for me, reparations are the first step to getting to a more egalitarian space, where then the power differentials can be hewn at. But I think that wealth gaps would be transformative start.
Can I say something? Yeah. I mean, I think that's a start, but it's still maintaining, within a value system of advanced capitalism. You mentioned Habermas, and I love his idea that, capitalism needs to grow to be sustained, and all the public sector is being taken up by, that economic system. And I think that the values of that are really not very true. I mean, you can't get enough money to secure your happiness. I mean, look at the people who have, more money than they know what to do with. I mean, there's still some suffering there. And so I think that, in addition to that, I think that we have to, and let me just say that I think all of the people who think that they're actually privileged by that system are not really, they're getting duped. They're getting duped by advanced laissez-faire capitalism. And I think that that's one thing that we need to do is bring everyone into as relatives, see all of us as relatives. That's a very indigenous way to think about it, and try to educate people about how their greed, hatred, and delusion that's causing all of this harm is doing nothing to maintain their happiness.
Yeah, we've struggled in the commission for that same reasons, like, is just endorsing checks for people going to, support neoliberal credit, credit domination even more. Like, how could we actually promote redistributive justice and degrowth at the same time? It's a really difficult mix, but.
So here's another very interesting question that I think might love to hear what the three of you have to say. While you draw from the epistemologies of the South, how would you compare or recognize the works of feminist women of color here in the US, including Patricia Hill Collins? Consider her works in the matrix of domination, structural, disciplinary, hegemonic, and interpersonal domains of power that shape human action. As we think about the politics of power and empowerment, centering Black, Indigenous, Latina, Mestiza, Asian, and other women of color is important. So as noted, the scholars you have cited and draw from are men, and to an extent hold privilege in truth-telling, particularly in academy. How can we have anti-racist work without gendered justice? So would one of you like to jump in there?
You want to start? I guess I made the mistake of leading with male authors, but in the book I do rely on the feminist scholars as well. But you're right. There's the tendency just in the oral praxis to lead with the ones that are male. So it's already demonstrated in my performance that even though I can take the time to do it in the book, when it's flowing, it starts with the male part. But Bonnie, do you have?
Well, I mean, I think Miranda Fricker, as you and I both are really loving her work about hermeneutical justice. I love that we take a space outside of that colonial patriarchal gaze and come up with our own meanings of things. I mean, I think that that's what historical trauma is. In fact, I'm pretty sure, that was created by Indigenous social workers and community health workers that were meeting. Samson Hirsa had all of these conference grants in the 80s, and people would get together, grassroots people, and just talk to each other. I'm seeing this where I am. Are you seeing this too? And that's where the theory of historical trauma came out of. And I think that Fricker wasn't around then, but I think the term hermeneutical justice or space, doing our own meaning making, really kind of describes that. But I think you're absolutely right. I mean, I will take that good advice to heart and try to cite as many women of color and feminist authors. I totally agree with you that that's our unconscious bias there, right? We're in higher ed. So there are certain names we always mention because they're the favorite people. But, I will try to unpack that with my practice. Thank you.
Troy?
Well, that's an extremely complex issue. Patricia Hill Collins, any number of Black scholars have talked about these issues for at least the last 40, 50 years. And if you go back to the 19th century, Frederick Douglass would be the first to agree to the notion that the linguistic framing of this is very determinative of the outcomes. That's at the moment, I think that's all I want to say.
Yeah, I mean, in the book, I use Maria Lugones. It kind of gets at that question that was asked about comparing Nkrumah and Quijano in South America, is that even when you're doing the work of decoloniality, there are still blinders. And so Maria Lugones would write about how the blinders of the original coloniality theorists didn't include the gendered component. And the same thing with me. I'm always looking at where my blinders are. It's that when you commit to this work, there's instead of the mountains beyond mountains, the Haitian saying, there's like blinders beyond blinders. And so, but it is, you're right. I like what Bonnie said about always committing to working with and thinking with our colleagues across the board.
So we have a question. Hello, as an undergraduate public health student at Cal, do any of today's speakers have advice on how to get more involved in social science research on the collusion between epidemiology and colonialism within global health?
Is Denise Hurd still on? I noticed that her microphone is off. I mean, she would be the person I would go to right away to begin to answer that question. I mean, that is also, Seth is here. Seth, you're on mute, but you've had direct experience with this. Students who really want to become involved and come to you with questions about the best pathways, the best mentors, best books to read.
Well, at Berkeley, some people who are doing related work could be Osagi Obasagi, who I believe trained under you, Troy. Mahasan Mujahid, Amani, Allen, in terms, but those are good questions. I'll need to keep thinking about that. And Denise, an undergraduate student, was asking, an undergraduate in public health at Cal asked about how to get involved in social science research about the collusion between epidemiology and colonialism within global health. I don't know if you have other thoughts too.
Well, oh, I'm sorry. Am I echoing here?
You're okay.
Oh, okay. I'm okay. Yeah, I think that there are a number of us that are teaching these kinds of ideas and concepts. Seth and I taught structural competency. Osagi and I are teaching critical race theory and kind of critical social epidemiology as a part of exploring health equity.
Someone you might read could be Jaime Braille. And Charles, did his book in English just come out?
Yes.
Okay. I bet Charles is going to get it to show it to you, but he has a few articles in English. He has a lot of articles and books in Spanish. And he's a very interesting thinker about colonialism, epistemic colonialism, and public health.
Yeah. Maybe I can mention that the two speakers we just heard, this was Denise Hurd from the School of Public Health and Seth Holmes from ESPM at Berkeley. And the title of the book by Jaime Braille that Dr. Holmes was mentioning is Critical Epidemiology and the People's Health, just published in Nancy Krieger's series at Oxford.
Yeah, I say in my book that my ideas are not my ideas because people like Jaime have been doing this since the 1970s with collective health and critical epidemiology. One thing I would want to say is that it is difficult, obviously, to get into this sphere because that's the way the system works. And just an example is I was in a faculty meeting yesterday at Harvard Medical School, where they've created something like 4 new tickets for faculty for people of color to recruit, and they're basing it on an NIH grant that they've submitted. And the language of the grant says that we want to recruit people of color that once they get here are destined for more R01s. So it's like already built into what they think of as their diversifying work to just recapitulate a system where you're never going to get an R01 to study epistemic violence. And so part of the difficulty there is how you cobble together, resources and allies and a network to do the good work without the major kind of supportive streams being available.
So we have another wonderful question here. What can or should we do as clinical health researchers in tribal health organizations? What can we do to turn the dial on the ongoing structural inequities you describe in the communities we serve? So perhaps for all three of you.
I have something to say about that. And just, to comment on what Jean just said about it's difficult within NIH. So I got an R01 to actually do an epidemiological study in the tribal colleges. We had 22 tribal colleges, because I do community-based participatory research, and they, I collected data on prevalence of mental disorders and risk and protective factors for that. And, it was successful in the data collection. We have an N of 3,200 people, probability sample from 22 tribal colleges, the most diverse, geographic sample of Native people. And, I'm sitting on that data set. I should be going after a secondary data analysis grant, but my partners have said, if you don't do strength-based, resiliency-based, cultural revitalization work, we're not going to work with you. And that's what a lot of community organizations are saying. The women's movement is saying it. The violence against women's movement is saying it. Sherry Hamby, Life Paths Institute is a big proponent of this. And that's what a lot of historically marginalized communities are saying. Hey, we lived 10 years longer than the European aristocracy did in 1491. Why don't we do cultural revitalization for healing and not, just having to be more Anglo, to be healthier? So I think that if RO went, I think that NIH needs to fund strength-based, resiliency-based, cultural revitalization, culture-centered approaches. Yeah.
And Charles, I could respond to these two questions quickly from Robert and Arun about statistical methods. Are they fundamentally racist instruments, or are they instruments used by racists? It's a really good question. I think, if you look at causal inference alone, that article I suggested by Sharon Schwartz, it really can only act as a conservative way of examining phenomena, because the well-defined intervention can only ever be very downstream. You're never going to tie hands cut off 200 years ago in Congo to Ebola outbreaks 200 years later. They can be on a determinative web, but you're never going to do a causal inference study that gets to them. And this is where Jaime Breil's book is rather brilliant. He talks about, the limits of causal inference and moving into this kind of determinative way of viewing things. As far as implying that there's no role for predictions of health outcomes, of course, I think, we should use our models or fables as predictors, but you have to realize what you're predicting. If you're opening up the social imaginary, and your forecasts only, say reduce infections because you've suggested that we should wear masks, instead of reducing disparities because you've not included an intervention into risk structure, like why certain people have higher risk than others, then you're actually furthering those disparities. Then by making your predictions, you're doing essentially racist work, because you're allowing the disparities to remain status quo. So all predictive science, and I don't think of it as a science, all predictive work has ideological presuppositions that you should recognize beforehand and be explicit about.
There are a number of questions on the table. I don't know if you want to grab any of them.
They're on the table?
Or on the Zoom, whichever way you want to put it.
Well, let's see. I mean, I want to go back to the importance of the unit of analysis and social research and epidemiology and health. If we begin with the individual and say that is the unit of analysis, and we therefore obscure the forces at play that shape that individual. I use the example of diabetes for a reason, because if you use the individual And then you go, quote, inside the body to look at genetic structure and now what's called genome-wide association structures. You have maybe a sample of 20,000 people, and you'll find something. You'll find genetic structures or genetic markers which are more or less distinctive because no two populations are going to be the same. You will conclude, therefore, that what you have done is science, what you have done is science fiction, because the context is what Gene described with the Congo. That is 100 years documented by Adam Hochschild's wonderful book about the Congo, cannot be exempt from the analysis of what's happening for current day individuals. But if you only look at individuals in the Congo now, look at their quote, genetic structure, what you will conclude is a deep, deep lie.
Thanks so much. Boy, one work that comes back to mind when we face these issues and the current dilemma now is a book called White Logic, White Methods, Racism and Methodology, edited by Tufuku Superi and Eduardo Bonilla Silva. We have another question here, another easy one. How can we push schools of public health and global health towards decoloniality, decolonization? To what extent is that even possible without burning everything down?
Well, I mean, I'll begin. I'm sure Denise has something to say about this. But way back in the 1970s, Berkeley School of Public Health was a kind of a beacon for a research operation, a series of questions which were analytic, went deeply into the whole framework that Gene is talking about, questioning the whole framework. What happened with School of Public Health in that early period was that they had what should we call it? A revisionist notion of what public health could and should be. And they began to dismantle the social science wing of public health. And the number of scholars who had been at the vanguard of this were let go. One became the Dean of Public Health up at Oregon State. But the point of this story is that the dollar began to make the most sense. And here's what I mean. In particular, they hired as the Dean of Public Health at Berkeley, someone who was a multi-millionaire. And he took the job, he said, for only $1. But when he came into the school, he then began to reframe it as a school in which pharmaceutical industry would play a much bigger role in the funding. And this began to shape the way in which scholars would come to Berkeley. So, I mean, Denise, you may have another rendering of this, but my understanding was that the School of Public Health actually was on a road that we've described here with Gene's work about collusion, but that got quickly reshaped and reframed by the $1 a year dean.
Denise, would you like to jump in there?
Sure. Well, thank you for those remarks, Troy. And I think what you said is very important, but I also think that the problem goes deeper into the history, of what public health is and when public health ascended, just in terms of if we think about the post-Reconstruction period, the role of pseudoscience, the role of eugenics, and that those were part and parcel of public health. And I think it goes even deeper. I had my students this year reading about the early gynecology experiments, and those were all done on enslaved women. And the students I had medical students, a range of different students, and they were reading this stuff and they said, "Oh my God, we're in a profession that's based in slavery. How on earth can we how on earth can we do anything radical when we're the framing of our education? It's really started in slavery, and there's so many remnants. I mean, just a few years ago, you had white medical students still believing things like Blacks don't feel as much pain, or they're thin, their skin is thicker, and those kinds of things. And I've always felt that public health is more progressive, but when I think about how far we are in the way we conceptualize things from some sort of community initiatives, and I think Bonnie is referring to some of these. So this concept, for example, of reproductive justice. Now, if you look in PubMed, you're not going to see very much on reproductive justice because it's a much broader framework than, quote, reproductive health or, contraceptive health, which is sort of what has been the main focus for women of color. But so that whole concept of reproductive justice, it's not really taught in public health. I mean, it's not part of MCA, maternal and child health. It's not the way HRSA thinks, but it's the way foundations think. And communities, all the philanthropy is working with communities of color, and they're talking about reproductive justice. And that frame, I'm going to tell you, is very far from what we're thinking about on a day-to-day basis in public health. And when, COVID-19 struck and Black Lives Matter and the, Color of Change, all these organizations, overnight people were epidemiologists. It was sort of great to see all the interest in public health. But what I realized is that, again, public health and medicine were out of touch with the way the community was thinking about it. And overnight, they had, like Zoomathons where there'd be 7 hours of Zoom of talking about health disparities and, health inequities, and without the benefit really, or without connecting to what was happening in public health. And, I've been doing this work ever since Bonnie was a student, right? I think Bonnie was in one of the first classes. And, people did not think that health disparities or health inequalities were a big thing in public health. I mean, I think until COVID hit, it was just something that people felt like, well, that's kind of the soft and fuzzy stuff that minority professors want to talk about. But I'm a media celebrity almost because there's so few people, that are, in the academy that are talking about these things. I mean, overnight, I've never done any research on infectious disease, but I'm one of the go-tos on vaccine hesitancy and vaccine equity now. So I would say that the field has, medicine and public health have a long way to go because we even the most progressive of us, I think, are out of step with thinking about things like, domestically, things like transformative justice, that it's just not part of our canon.
Regarded as political, not science.
So thank you for that wonderful response, and thank you for all of your work, Denise. We have time for one last question, and I think that one member of the audience kind of wants to spark a debate with regard to the issue of reparations, and especially reparations in relationship to the capitalist underpinnings of global public health. So reparations, is that the answer? If so, exactly what does that mean, and how should we go about thinking about reparations?
In 2 minutes.
Yeah. It would be a several year conference, but I love Bonnie's input because we do struggle with that, and the different the section leaders all have different approaches. A lot of them aren't just we're demanding monetary reparations. Joe Gahn is leading the section for American Indians, and he's working in the space of historical trauma. How do you repair historical trauma? And really hasn't brought up anything as far as like monetary ways of repairing it, but still thinking of justice as repair instead of just like the aid or the investment modalities. But I agree that it is thorny and problematic, and it's not the right answer, but it seems to be there. A lot of people, a lot of groups are sort of demanding this initial kind of evening of the playing field before we can even get to some of the more substantive discussions.
Yeah, it happens that 2 days ago, the New York Times published a story. The headline was "Reparations Determined for Evanston, Illinois." That's almost my hometown. I'm from Chicago, but I went to Northwestern. Upon closer examination, the article pointed out that it was not really reparations. It was anyone who could claim a grandfather or grandmother who was in slavery could have $25,000 towards a home loan. That was the reparations. Not really.
Right, and our section, you know, our section leader Sandy Darity looks at those and thinks it's kind of dividing and conquering. You know, I think he calculated if you had one of those Evanstons every day for 8,000 years, you still would not get the total that is owed to descendants of slaves. So it gets very political. I've even seen the quarrels between the descendants of U.S. slaves and descendants of Caribbean slaves because they have different. One is to UK, one is to US, but it allows them to be, you know, the divide and conquer approach. So it's a movement.
So, Bonnie, I think you may have a last word here.
Well, I mean, I think that part of the healing is going to come when our white relatives realize that they're getting plagued too, you know. And I think that I don't think happiness is like just having, you know, a lot of wealth. I mean, and we know that that's not it. And I think it comes from us understanding our interconnectivity and, you know, really drawing on that. So I think that definitely Indigenous people, I think, you know, we're doing cultural revitalization. That's what our interventions are now. And language revitalization. They're very positive, strength-based things. And I think that I'm on the board of a great organization called White Awake. And, you know, they're training people that, you know, European Americans are having their culture stolen from them by the 1%, and that they should also realize that they're getting played by this economic and cultural system that doesn't represent them either. You know, I don't want to do that work. I will support it. But, you know, it's up to my white relatives like Gene to figure out how to do that. Yeah.
Well, thank you so much. I would like to first thank all of the participants, including those of you who sent in really fascinating and quite challenging and complex questions, and particularly our presenters today, Eugene Richardson, Bonnie Duran, and Troy Duster. I thought this was a fascinating discussion. I learned a ton. I've made a million notes. I'm going to be thinking about this for a long time. Thank you so much.
Thank you, everyone.